Good afternoon, everyone. I hope you're all keeping safe and well. My name is Meaghan Stovel McKnight, and I'm the Chief Operating Officer of the Princess Margaret Cancer Foundation. Thank you so much for joining us today for our second episode of the High Touch, High Tech webinar series. Within each of these sessions, we will be introducing you to some of the world's leading cancer experts of the Princess Margaret. These researchers and clinicians are embracing digital connectivity, emphasizing comforts and access for all patients, and innovating to provide care beyond the walls of the cancer center. They are transforming, reimagining, and redesigning the future of cancer care. Princess Margaret Cancer Center has achieved an international reputation as a global leader in the fight against cancer, and it is because of the scientists and researchers that come from all around the world to call our center home. Last month, we spoke with Dr. Gary Roden, Director of the Cancer Experience Program, exploring the human touch of cancer care and the interconnected well-being of cancer patients, staff, and trainees. Today, we'll be meeting with Dr. Gelareh Zadeh and learning how she is shaping the future of neurosurgery. Now, before I introduce Gelareh, a reminder that we will have time for audience questions and answers towards the end of the program, and we would love to hear from you. You can submit questions through the session using Slido. The link can be found in the YouTube description directly below the image on your screen. Today, I am so pleased to welcome Dr. Gelareh Zadeh. Dr. Zadeh is a neurosurgical oncologist and senior scientist at Princess Margaret Cancer Center, where she holds the Wilkins Family Chair in Brain Tumor Research. Dr. Zadeh is also the head of the Department of Neurosurgery at Toronto Western Hospital and medical director for the Krembil Brain Institute at University Health Network. And as a professor of neurosurgery, Gelareh was appointed the Dan Family Chair in the Division of Neurosurgery at the University of Toronto in 2020. This appointment makes her the first woman to lead one of the largest neurosurgical programs in the world. And on top of that, earlier this month, Gelareh was recognized as one of the top 25 women of influence for 2021. Welcome, Dr. Zadeh.
Thank you, Meaghan. Thank you for inviting me.
Gelareh, let me begin by congratulating you on receiving the 2021 Women of Influence Award. Such a wonderful recognition for your extraordinary accomplishments. Thank you so much for joining us today.
My pleasure.
Now, how are you and your family doing during this crazy time of the pandemic?
You know, I think looking at the positives in everything we face, the positive has been that I have more time at home. The travel is restricted, so I don't go to as many conferences. And I have to say that's the positive that I focus on to get us through this very unexpected time in all of our lives. And I think learning that, in fact, we can catalyze and quickly adopt virtual platforms such as this to increase communication with our patients and with each other, locally, nationally, globally, has been a huge positive. And really just taking it a day at a time, staying focused on what drives us, staying as positive as possible, finding new ways to focus some of our energy, and hope that, you know, we can get through this storm together and learn in the process, respond to the challenges and become stronger, which is a step, in my opinion, beyond resiliency. So I think those are really some of the ideas that constantly go in my mind. And I keep thinking, what is the future going to hold, and how can we better integrate technology into anything that we do on a daily basis, whether it's clinical care delivery, research, academics, education, and on a personal level. Perhaps it's an opportunity to find ways to stay connected with friends, family, and find new ways of connections as well.
Wonderful words of wisdom. You know, they say necessity is the mother of invention, and we are
Yes.
doing a lot of inventing these days. So it is very exciting to see what the future holds for us.
I agree.
Now, looking back, you are looking at your role today. You wear many hats at the Princess Margaret Cancer Center and University Health Network. And we'd love to understand a bit more about these different roles. So first, you're a neurosurgical oncologist. What is neuro-oncology? For those in our audience who may not know, what can you tell us just about the breadth of this?
Sure. So neuro-oncology encaptures all of brain tumors. And if you look at our textbook of brain tumors, we have 150 different distinct categories based on the World Health Organization. However, on a day-to-day practice, we see approximately 10 to 15 of those different types on a regular basis. And they can be classified as benign growths to malignant cancerous growths. However, because they grow in the brain, even a benign growth is a concern because it causes mass effect, increased pressure, impacts the function of our brain, spine, and peripheral nerves as well. So really, it's a range of different tumors that we can develop anywhere on our neurocranial axis. So along the brain, spine, and peripheral nerves. And the most common one, perhaps one that's received more attention recently, and rightly so, is the tumor that Gord Downey would have had as a glioblastoma. It's the most deathly cancer that we have in adult life, unfortunately. The prognosis remains very poor, and that's where a majority of our research focuses, to better understand the mechanisms with which this tumor evades treatment and resists treatment. And then the most common brain tumor we actually have is meningiomas, which is a huge focus for me based on my clinical practice and also based on the need for research to be able to identify additional treatments beyond surgical intervention, which is after we take out the tumor, what next would the patient need to avoid recurrence, regrowth, and progression of the residual. And then some of the tumors are classified based on location. So whether they're at the skull base, below our ears, or above. The ones that are below our ears in the skull base area are those that have very intricate involvement with very fine nerves that we call cranial nerves that come out to make our function in our head and neck possible and really makes us who we are as people in our function. Those are the types of operations I do 80% of the time. They're operations that I really enjoy. It takes a significant amount of focus and attention during surgery. And it takes a lot of under the microscope, fine dissection, understanding the anatomy, preserving neuronal function. So for those reasons, I would say I do skull-based surgery, which is removing tumors in that location.
Very amazing. You know, it's the more and more I learn about cancer, I think we use this one word cancer, but it means so many things. I mean, in brain cancer alone, you identify there's 150 different types. It's extraordinary. It just and the concept of the brain, how much there is to learn. You're also medical director of the Krembil Brain Institute. So can you tell us about your mandate at Krembil?
So within UHN, we have signature programs, so cardiac, neuro, cancer, transplant. And each of these programs really bring together multiple disciplines that work towards disease processes that really put the patient at the center to allow the best streamlined care for the patient, smooth transitions in their care. And in Krembil Brain Institute, we focus on a wide range of neurological conditions from developmental to degenerative. So degenerative most commonly recognized as dementia, Alzheimer's, Parkinson's disease. Movement disorders, again, Parkinson's straddles that. And also to the other extreme, which is neuro-oncology and tumors. I see my mandate as bringing together the many disciplines that fall under Krembil Brain Institute as the Neuroscience program of UHN, as a flagship program because we have so many subspecialized faculty and staff members that work in this area. And partnering with each other and growing together as a team is what makes our environment richer and what we can do for patients and translate research most exciting. And I would say that we have one of the largest neuroscience programs at the Krembil in North America, as we have the largest neurology team, neurosurgery team, interventional neuroradiologists, neuropathology, etc. And each of them are very highly subspecialized, very well recognized in their area and field internationally. And so it's really a pleasure to bring teams together and see the results of this partnership and collaboration, and to be able to actually think of new ways that we can treat some of the disease entities that we're faced with.
That's really something that's quite special at Princess Margaret at UHN is all of these adjacent programs that we can integrate across, and of course our affiliation with University of Toronto, where you've recently been appointed the Dan Family Chair in the Division of Neurosurgery, making you the first woman to lead one of the largest neurosurgical programs in the world and the first to be named to the chair in Canada. What does this mean to you?
So I would have to say that wanting to lead our academic division at the University of Toronto has been a long-standing dream of mine. In fact, when I met Dr. Jim Rutka, who at the time was the division chair, many years ago, almost 20 years ago now, I remember thinking that this is the person I'd like to become. And the reason for that is that we will define the forefront of our field and define where we want to go in the field of neurosurgery and do all of the exciting things that we do in neurosurgery, in particular the academics, as majority of us are surgeon scientists, surgeon investigators, and also combining innovation and technology in how we improve in our surgical care delivery of neurosurgeons. And then a second strong influence for me really has been that the University of Toronto environment, as you mentioned, we have the affiliate hospitals, but we're really all housed within University of Toronto, brings with it such a rich environment for collaboration, where it allows that us as individuals, as faculty members, scientists, clinicians, to grow and collaborate with each other. And that's in fact what motivates me to be wanting to, again, lead a group that allows us to build collaborations and bridges within ourselves and outside. So internally have more partnerships with each other where we can look at disease processes from different perspectives and angles to be able to offer new treatments and new approaches.
Incredible. Now, last but not least, why was coming to the Princess Margaret the right choice for you?
So I would say, again, much like what I said about the University of Toronto, Princess Margaret is an extremely rich, fertile ground for collaboration. There are extremely competitive, smart, and collaborative scientists at the Princess Margaret Cancer Research Institute. There's outstanding clinicians who, again, are at the forefront of their field, in particular in the area that I have an interest in neuro-oncology. We have some of the world leaders here. And so, again, it provides this opportunity to create a spark, to create collaboration, to bring ideas from different perspectives of my career, clinical and research, to be able to answer some of the key questions that we're faced with understanding disease, in particular brain tumors, and how we can improve our intervention for brain tumors, the way we manage the patients, and introduce new opportunities for not just therapeutics, but management of our patients with brain tumors. And in addition to the rich environment locally for the Princess Margaret Cancer Center, as you mentioned again, we are situated in a position where we have multiple other key leading institutions in and around this small block of Avenue Road, and also our partners at Sunnybrook within the university that enhance everything that we do. So if you look at my research program, the many collaborators that I have are really only made possible because of such a rich environment being in place. And I think another key aspect is, and I really experienced this when I went away for 2 years at the start of my career, is that you really need a core critical mass of like-minded people to support the research and academic activity that you do, that have the same drive, that have the same vision, and have the same interests to be able to push the envelope, to be able to define the forefront. And so those would be the reasons that I'm proud really to be part of the Princess Margaret Cancer Research Institute. And I would say that being a senior scientist at the Princess Margaret Cancer Research Institute is something that I'm extremely proud of. I would have not thought that I would be able to hold this position, but as a surgeon, it means a significant amount to me to be able to have that opportunity, to have the environment to work with some of our most amazing clinicians, scientists, and scientists.
Now let's go back before you came to Princess Margaret and UHN. I'm sure your story would resonate with many of our viewers. So we'd love to learn more about your journey that led you to science and medicine.
Sure.
Now, you were born in Iran and then educated in England, Iran, and Canada. Tell us a bit about your journey before med school.
So before medical school, I was actually quite set on becoming a mathematician. I, in fact, entered the actuarial mathematics degree with possibly, moving on to becoming a banker. And I was really happy. I was doing well. Math was something that came naturally to me. I don't remember any of it now, so I can barely add currently, but at the time I seemed to have the capacity to understand calculus very well. However, as fate happens, I had one professor during my second year of undergrad that I just was unable to comprehend her lectures. And at the time, I always thought it was me. But with hindsight, I actually think maybe that wasn't her strongest suit. And so she was having trouble explaining and teaching the course. So after a lot of deliberation and anxiety, I dropped the course, but that course was needed for me to finish my degree. So I was at a bit of a loss as to what to do. And two of my friends who I knew from the short period of high school that I went to in Winnipeg said to me, well, why don't you write the MCAT and go to medical school? And so, as they say, the rest is history. That's what happened.
Brilliant. Now, in medical school, you decided to enter the field of neurosurgery.
Yes.
And if we go back 20 years ago, I understand you were likely faced with a real lack of women role models in that field.
Mm-hmm.
So, in fact, I believe only 11% of neurosurgeons in Canada are women.
Yes.
Can you tell us what attracted you to this field?
I really like neuroanatomy, the studying of the brain function, the different structures and what they do. And originally I thought maybe I would want to be a neurologist, and I did an early elective in neurology. However, what happened is I was actually sitting on the wards one day when I did this early elective in my first year of medical school, the summer after first year. And the neurosurgeons came by and asked who I was and what I was doing, and I explained. And Michael West said to me, you don't want to do neurology, you want to do neurosurgery. Come to the ORs with us tomorrow. So I took him up on his offer, woke up at 7, went to the OR, and that was it. I saw the anatomy of the brain, an open operation, his extreme focus and concentration during surgery, and him and Norm Hill and Derek Fewer, 3 gentlemen who were the neurosurgeons in Winnipeg at University of Manitoba, were beyond supportive of me. And in fact, Norm Hill, who in his earlier life had been a football player for the Winnipeg Blue Bombers, kept repeating to me that we need more women in this field and we need to make it a softer field, and encouraged me. And it's really because of those 3 gentlemen that I went into neurosurgery. I felt supported. I felt really safe that they're going to have my back when I go into this field. And true to form, they were very supportive of me. I moved to Toronto to do my PhD in the area that I wanted to do my PhD, and I couldn't find the appropriate mentor in Winnipeg at the time. And they didn't waver in their support of me. I finished my training in Toronto, obviously, and then I continued here. But I do always acknowledge the first seeds that they planted in my brain to pursue this area. And I have to say, Michael West, Derek Fewer were outstanding individuals, charismatic, kind, caring, excellent teachers. And so all of those features they embodied, and it's really what attracted me to the field. And, I think much like anything else in life, people who come across your path really change and shape you. And I would say they were key, instrumental people. My PhD supervisor, he unfortunately passed away at a young age in 2011. He was another person, Ab Guha. Our current Department of Surgery chair, Jim Rutka, himself is a great mentor. So you're correct. I've actually never had a female mentor. I have an excellent female colleague, Dr. Meaghan Hodai, but I've never had the opportunity to have a female mentor. But I would say The mentors that I've had in my career path have been outstanding, and I think recognize the value and the importance of supporting a female within neurosurgery. And of course, the last name to mention is Princess Margaret's senior scientist, Dick Hill, who just showed me what mentorship was about. Was an amazing fortune for me to have come to find him as a mentor. And in fact, so much so that I started the Mentorship Award at Princess Margaret Research Institute named after Dick Hill, because he was truly the person who taught me what it's about to be a genuine mentor and a proper mentee.
Yeah, I mean, it really shows the incredible impact mentorship has had, and I think has in the field of medicine.
Yes.
No, you said he showed you or told you what it meant to be a great mentor. What does it take to be a great mentor?
Well, I think first it's a two-person partnership. There's a mentee and a mentor, and I think the mentee has to have equal responsibility in the success of the process. As a mentee, in my opinion and my experience, you have to be open to accepting feedback, suggestions, course corrections, refocusing some of your efforts. As a mentor, I think you have to really individualize the person and understand who they are, what makes them tick, what strengths they have, where perhaps there's opportunities to improve, and prioritize them ahead of yourself. And that's not a minor task, because as academic physicians, as academic scientists, our own success is obviously our priority. But I think to be a good mentor, you have to really understand the mentee's priorities and put them ahead and think for them as to how they can get over challenges, how they can get over stumbling blocks. So one thing that Dick Hill did for me actually wasn't so much to teach me about science, it was to help me every week with grievances I had about things that happened at work, to say, well, why don't you look at this problem from a different perspective? He would go and look up literature that would support my perspective, that perhaps sometimes as a female, I was put in positions that I was viewed, assessed, and perhaps reacted to differently from a man. And he would find literature to support that and say, well, now let's think of how you're going to tackle this issue. I mean, it's very rare to find an individual like that. So, going back to your earlier question, why Princess Margaret? I really don't think there's many other centers that would offer an individual who was so giving of his time, his intellect, and supportive of a junior faculty like myself. And it was my fortune to really come across him.
That is pretty exceptional. And I imagine you've carried that forward as a mentor several times in your career.
I hope so. I hope so.
Yeah, mentors often say you learn as much from your mentees as they learned from you. What have you learned from mentoring others?
So I would say the biggest area of mentorship for me is directly in the OR. And each time I do an operation, it's not an exaggeration. Each time really with a new resident, new fellow, I learned something from them, whether it's something that they do differently, because we approach surgical skills very differently. I see that they do something different, but also I learn in the process of making them understand the anatomy as well. So that would be one key area. And then the second, of course, is in the lab. There's approximately 20 people in our lab, and there's multiple facets to mentorship there. One of them is professional interactions with each other and team building, collaboration. I think in order for a lab to be successful, you really need to work effectively together. The sense of competition has to be eliminated, and mentoring to get people to reach that level where you see value in collaboration and partnership as opposed to competition is a process. And then, of course, I learn a lot from the trainees who come through, because they are a invaluable resource because of the intelligence they bring with reading, with knowledge that they bring, and pointing out new approaches, new experiments that we can do, new technologies, etc. So they really keep me actually on my toes, engaged, active, and I learn from them in that process. So those would be, I think, in my opinion, the two areas that I probably have the most joy out of mentorship.
It's wonderful. Now let's dive into some of the high-tech aspects of your career, the research that you're doing, which is truly groundbreaking. Maybe give us just sort of an overview. How has the field of brain cancer research changed since you started?
I think the biggest impact has been on genomics and epigenomics, understanding some of the signatures associated with the brain tumors, recognizing that there are multiple classes, as you mentioned, not all cancer is the same, and not even all subtypes of cancers are the same. So for example, again, glioblastoma, we now know that there are distinctly at least 4 categories of glioblastoma. So if I develop a glioblastoma, it will not be the same as the next person. And then going a step further, beyond the 4 main categories that you can put the glioblastoma in, there are specific genes that are mutated that impact outcome. It bears on how we manage the individual patient, how we counsel them for prognosis, and bears on decision-making for treatments that we offer the individuals. So I would say that's probably the biggest impact, the understanding that there are signatures outside of what we could see traditionally under the microscope in histopathology. And then the other area that's shifted significantly is recognizing the value of rapid translation of results to clinical practice, so that you would want to have technologies and novel approaches to really be making an impact in addition to understanding biology. And so some of the work that I would highlight is the more recent work with Daniel D Carvalho, which I think the circulating tumor DNA methylation signatures will really transform how we approach patients with brain tumors. We can ultimately envision moving away completely from needing to do a biopsy and being able to follow a patient with a blood test and making that a more sensitive test compared to what we use currently as standard, which is an MRI. Another area which we've had really very promising results with is the injection of modified adenovirus within the tumor cavity. We were the leading center for recruitment of to the clinical trial, and we're just finalizing the results. It was a late-breaking abstract at the Society of Neuro-Oncology because we've had very positive outcome for those that have controlled disease and progression-free disease. So those are some of the areas that I think have evolved dramatically since I started my career, and I envision that it would continue in this direction moving forward.
It's just, it's so amazing to hear all of the directions this is going in. I'd love to just understand a bit more about the work that you're doing with Dr. Daniel D Carvalho and using advanced technology and machine learning and blood tests to classify these cancers. Can you just maybe tell us a little bit more about this very exciting work?
Sure. So again, going back to the richness of our environment, providing opportunities for collaboration, nowhere else would I have come across somebody as strong as Daniel D Carvalho in the scientific world, who has really made a revolutionary discovery in techniques that he's applied together with his team to being able to pick up the methylation signature of the circulating DNA, to be able to accurately diagnose, but more importantly, subtype the tumors that we have. And for us, where the convergence of his work and mine allowed us to make a huge contribution, in my opinion, was to demonstrate that you can accurately do so for brain tumors. Traditionally, it's felt that the blood-brain barrier prevents egress and, in turn, shedding of material into the bloodstream. However, we've shown that, in fact, the technique can be applicable to brain tumors with very high accuracy, diagnosed in subtype brain tumors. And ultimately, I could see that as we prove prospectively in real time the value of this test, that it will become a mainstay of clinical management. I would also add that since 2015, when we've introduced the methylation program in our lab, it has now become a mainstay in clinical practice in that we've incorporated methylation analysis of the tumors to be able to more accurately subclassify and diagnose brain tumors. And in 84% of the challenging cases, we're able to make a meaningful change in the diagnosis that then ultimately has, within 15% of our cases, an impact in how we decide on clinical management, which is very impactful, again, in my opinion. And so those are some of the areas that I think are representative of the success of the rapid translation to clinical practice. Discoveries that we make that we can take into a practical application that allows adoption by a multidisciplinary team, going back to your question again earlier, where like-minded people want to have integration of the cutting-edge discoveries to be able to make a change in how we manage our patients.
This is really the kind of incredible opportunity that's at Princess Margaret, where you have scientists like yourself and Dr. D Carvalho who come here and where this work is being done in labs and able to translate to patients so quickly. The concept of diagnosing a brain tumor through a blood test, just incredible impact on patients and the outlook for brain cancer research and care.
Yeah, and I would say the potential for this to extend beyond diagnosis is to follow and monitor patients for response to therapy and other aspects of this that are quite far-reaching into how we approach brain tumors in general.
Amazing, amazing. Now we know brain cancer research is a truly global field. And while we have a real nexus of talent here at Princess Margaret, I imagine you're working with a lot of scientists and clinicians from around the world. So what are the other centers you partner with outside of Canada in your research?
So that's a good question, Meaghan. For the year of 2020 and 2021, I'm in fact the president of Society of Neuro-Oncology. Another position that I've dreamed of holding for many years. Of course, it falls squarely into the period of the COVID pandemic. So all of our conferences and educational content has to be delivered virtually. But as I mentioned at the start of this session, it's shown us a whole new world of how we can connect more broadly, globally, with colleagues on a more frequent, more regular, and more ready basis. And so I would say some of the key areas that I continue collaborating with are, we had a researcher with us at the McPheeters Hamilton Neuro-Oncology program, Ken Aldape, who is at NIH, and we continue partnership with him and the team that's in neuro-oncology there. We have partners at Northwestern in Chicago. We have partners at University of Minnesota, primarily in the area of neurofibromatosis, an area I didn't touch upon, but very much a focus in our lab for research on brain tumors, spinal and peripheral nerve tumors. And then there are other partners throughout based on specific projects. So we have close collaborations with Dana-Farber, with Brigham and people in UCSF, and then equally in Heidelberg, Germany, and other areas within the UK. So it's a global network. And with each project, it's tailored to where the strength of other researchers and interests and commonalities in our projects lie.
It's another real strength of the sort of the global presence of Princess Margaret. I don't know that many people know that we have partnerships with over 100 institutions, with over 500 institutions in over 100 countries. It's a really global partnership that we're part of in conducting research around cancer. Mm-hmm. One of the things you mentioned there, Gelareh, was around how COVID's impacted a lot of your international work. What role has the pandemic played in your clinical practice, and how has it sped up the need for technology in patient care?
I would say the biggest change for us has been moving to adopting virtual clinics. And so at the start, though it was very foreign, we felt that the art of medicine is lost because a lot of it is in body language and being present, and the small gestures that you make in presence in face-to-face or lost in virtual. But I think recognizing the value of virtual, which is not to drag people from far distances to see us for the few minutes that we have time for our appointments, to be able to see them on a more frequent, regular basis, to be able to actually provide opinions, again, in more far-reaching areas, has catapulted us to accepting this. And in fact, I would say, if I reflect back on the year, the biggest change for me has been that I was extremely frustrated with virtual clinic a year ago, whereas now I enjoy it very much, and it's a mechanism for us to actually stay more connected with our patients. The downside, of course, like I said, is I think when you accept to have surgery and agree to an operation, somehow the looking somebody eye to eye and building that trust and rapport for, really leaving your life in somebody's hands is something that still is very foreign to me. And I cannot praise all of our patients enough for the bravery of going through this process, going for surgery without ever having met me in person. It really, it amazed me. And I think people are so strong to actually accept this mode of care. I would think that's the biggest impact. I think the ability to reach broader audiences to disseminate your message on the academic side is really the most impressive for me. So a best example for me is that through my role as the president of Society of Neuro-Oncology, I help establish other societies for neuro-oncology that focus on research, clinical practice of brain tumor management. And one of them was to be set up in Pakistan. And so in the start of the summer, I was planning to go to Pakistan. The intention was we were going to launch together with the society members in Pakistan. And, typically in a scenario like that, we would have 100 to 200 people attending. Whereas when we did this by Zoom, we had 1,300 people attending, not just from Pakistan, but the whole region. So you could see the magnitude of impact that people can have with these platforms.
I think you talked about that at the beginning, is getting through this not just resilient, but actually coming out stronger. And these are some really beautiful examples how that is transpiring. Mm-hmm. One of the last areas I'd love to talk to you a little bit about, Gelareh, is mentorship and women in STEM. The UN International Day of Women and Girls in Science was last week, and it's a day that shines the spotlight on the fact that women and girls continue to be underrepresented in STEM. What was your experience in coming through the STEM field, and what do you think are some of the challenges facing women in STEM today?
To be honest, I really think there's a strong environmental and cultural component to this concept that women are either not good at STEM or they're not interested in it, etc. When I came from Iran through England to Canada, the idea that girls are not good at math was never something I had heard about before. As I mentioned, I really enjoyed it. It never occurred to me once that I should not be good at it. Nobody ever said this to me. And in Iran, we had an all-girls school. Women taught us. And I had outstanding math teachers. They were women. The concept was so foreign to me because when we landed in Winnipeg and I went to university, that's a lot of what I heard, that how can you be good at math? Oh, you're a girl and you're good at math. And I thought, what is going on here? And I think, if you tell somebody you're not good at something, they're probably not going to be good at it. So I do think there's a huge influence of this belief that somehow some categories of people are not good at things and some are better at other things, right? And it's not just related to STEM. I think it's preconceived ideas that we enforce upon ourselves in all areas. And this really relates to accepting diversity, because as a consequence of not being open to accepting that we each have strengths in our own individual ways that should not be defined by preconceived ideas, we are missing out on huge opportunities where talent lies and we're unable to see it. So I really think that there is no difference based on your personal background, whether it's gender or otherwise, as to what you're strong in. I think the point is that nothing comes in life easy. So even if you have talent and strength, you have to practice at it, you have to work at it, you have to work to find where your strengths are. And some of them don't naturally manifest to you over the course of your training. It's probably, some of it is by coincidence and serendipity, and some of it is by hard work. So those are my general thoughts about this, because I have given it more and more thought. And like I said, it still boggles my mind that anybody would think that we're not good at science, engineering, medicine, technology, etc. It's just, I think it's a false belief. We need to eliminate that.
Unconscious bias.
Mm-hmm.
Yeah, that's amazing. Or in some cases, conscious. That's amazing.
Mm-hmm.
So looking forward, what do you think are the biggest challenges still remaining in your field? And what do you see the field of neuro-oncology looking like in 5 to 10 years' time?
Well, in the field of neurosurgery, I think the forefront is going to be adopting and working on perfecting machine-brain, machine-spine interfaces for degenerative conditions in order to restore brain function and or preserve it. I think this will really make an impact on who we are as people. Just like we can replace joints, we can replace cardiac vessels, we can replace organs. We can't do that with the brain, but there are modulations that will most likely allow us to halt, slow down, and replace degenerative brain. So that's in the field of neurosurgery, neurosciences. In the field of neuro-oncology, I think we really have to expand our research to focus on predictive measures. I think majority of the tumors that we see in our practice as neurosurgeons, by the time the patient is diagnosed, it's a little bit late. And we need to have more predictive markers, more accurate measures of being able to diagnose and detect tumors before they occur. So much like a mammogram that allows you to have early testing, we need to find that key test, and perhaps it will be our CF-MEDIP that will ultimately become such that we can integrate it into a test that we would look at as a marker to see whether or not there's perhaps small cancerous cells that are starting to act up in our brain. And that, I think, will have the biggest impact in the field of neuro-oncology.
Well, I know we are all very excited to see how you continue to shape the future of neurosurgery and neuro-oncology in the decade ahead. Before, Gelareh, we open up to questions from our viewers, we'd like to have a little rapid fire question fun. Just got a few questions that we like to do this because our supporters love to learn a little bit about the people behind the science. Okay. So I've just got 8 or 9 fun questions I'm gonna give you. Okay, First one, favorite musical artist or band?
I'm really boring. I would say Mumford and Sons probably is the one I would listen to on a fairly regular basis recently, but it changes. It changes from year to year.
Nice choice. First place you will travel when it's safe to do so?
London, England. This I've thought about a lot. It's either going to be Newport Beach, California, or London, England, but I think it'll be London, England.
What's your favorite food?
I don't really have a favorite. I mean, my daughter asks me these questions, and I'm not that sort of a person. I don't have favorite things in any category. I would tell you my favorite food is oatmeal.
All right, it's a good solid choice. Good solid choice. Dinner with one person, dead or alive, who would it be?
That also changes on a regular basis. I would say, you got me, Meaghan. Dinner with a person, dead or alive currently. I'd have to think about it because COVID has really impacted and shaped what I think actually on a daily basis.
We can let you think about that one for next week.
Let me think about it for next time.
All right, advice you would give your 20-year-old self?
Yeah, I would say the natural answer I think most people actually give to this question is not to worry as much and enjoy life more. The truth is, there's no way to go back and see if that would have landed me where I am today. And so I'm a little bit reluctant to give that answer. However, I would say that I would really tell myself to have been more confident in my own capabilities. And some of it probably came from the fact that I moved quite a bit and had to adjust and adapt to new systems. And so I was not entirely confident that I understood my environment as well. But at the same time, I think that allowed me to become a more adaptable person. And so I learned in the process of knowing what the new environment brings and learning how to manage it and work well in it.
All right, last one. Give us a really interesting, fun fact you know about the brain.
It is not a fun fact, but it's an amazing fact. The structure that's called the fornix and the foramen of Monroe is where our memory is essentially all comes together in some regards. And it is the most beautiful thing you'll ever see anywhere. And every time I do an operation like this, without exception, I feel amazed. It's the anatomy is so beautiful, it's irreproducible. I mean, I think it's an extraordinary fun fact.
That is extraordinary indeed. All right, we are going to open it up to questions from our audience. First one, is glioblastoma hereditary?
No. So in other words, if a family member has it, it cannot be passed down to offsprings, and there aren't trends within a family line, unless there are some predisposing conditions. But you would be aware of those predisposing conditions that you would have had to make you more likely to developing glioblastoma. But the more straightforward answer is no, it's not hereditary.
Okay. Next one. Does your research always end up where you envisioned?
Yes and no. I mean, I think one of the key lessons I've learned is that the hypothesis we build, the questions that we ask, need to be comprehensive enough to account for possibilities of outcome, so that it's not linear. So in fact, if I'm asking a question, I know that there may be 3 or 4 outcomes. And so I'm not surprised if one of the 4 outcomes happens. So although it may not take me to the one that I think is the most likely outcome, there are outcomes that I would have anticipated and predicted. On occasion, where there's outcomes that I could have not anticipated, of course, it's amazing. Either it's positive, which is an amazing discovery, or it's a negative, which makes us think even more. So that would be my answer.
Okay. Next one. Any advice for young people considering entering your field?
Yeah, I mean, I guess by my field, you mean neurosurgery or perhaps research in this area. In general, I would say to be ambitious and explore what you want to get into in a fairly thorough manner. And so enrich your experiences, your exposures, your ability to see as much of the field as possible and aspects of it that impacts your life beyond the specific areas of the field. In other words, how does it affect your personal life, your work-life balance, who you represent ultimately in that role, etc., before you make the decision, and make sure that it's really something you like to do, because this cannot be considered a job. It has to be a career and a life vision that you want as who you want to be, rather than a job that you have to go to. It requires so much commitment, so much energy, so much passion, that I think it has to really be part and parcel of who you are, to embody it and to really enjoy it. And so I would say that that's, again, what I would answer to that question.
It's very inspiring. You answered a little bit about this earlier in the interview. Yes. How has COVID impacted your clinical practice and your research?
mean, one point that I didn't make, some of the comments I made earlier, but one point I didn't make is really the restriction and social distancing and being able to see colleagues, to hang out, to exchange ideas freely, spontaneously. You know, I have to wait for the next Zoom link to connect to one of the guys in the lab, or the Zoom link to our business meeting to just chit chat with one of my colleagues. And losing that, I think, has had negative impact. It would be a lie if I said that that's been a positive. I think that's actually a huge negative, and I look forward to the day this social distancing is lifted completely. We're safe to do so, and we can return to the connections that we make with each other.
You talked a little bit earlier about women in STEM and some of the barriers being cultural. Are there any country-wide programs for women in STEM in Canada? What is Canada doing to encourage women in STEM?
So I have to say I'm not aware, and it's not, it's really not something I could comment on from a Canada-wide perspective. I know that locally as an institution, as our programs that I have influence on, sessions like this, being able to raise awareness, reach out to schools, high schools in particular, reaching out to undergraduate programs, and really making sure that there's awareness that there are different perspectives of those of us as women who go into STEM and how we promote it. I'd have to actually, this is a question that's going to now make me think about it more, look into whether there are official Canada-wide programs. I know they are in existence. I just couldn't tell you which ones they are.
No problem. Can lifestyle choices contribute to glioblastoma?
Not that we know of. Not that we know of. So, you know, for example, smoking doesn't create glioblastoma. Excess drinking doesn't. Not that we know of for life choices, your diet, etc. There's some literature about viruses, and I definitely have some thoughts about this. But there's some literature that viruses, the common cold, for example, could do this. There's a definite connection between some cancers and viruses. So whether there is a connection that we just haven't discovered, I don't know. But there are no currently known life choices that can result in a glioblastoma.
Okay. What are the new techniques and treatments to treat brain injury and concussion?
So a fairly broad question. Brain injury has a wide range, so it can be from stroke, it could be from head injury, trauma, car accident, knock to the head from a fall, etc. So depending on the pathology, as I mentioned, there's some areas that we can do neuromodulation to improve some of the function. There's some transcranial stimulation that helps with some processes of recovery. And the concussion is also by itself a fairly broad category. It depends on the degree of concussion and the impact of it. Some of it, again, can be therapy that's given with cognitive therapy, physiotherapy, but some of it is really at the extreme range and impact of concussion. Perhaps, again, some of the magnetic stimulation is an area that you can explore currently. And I think in the future, the machine brain interfaces hopefully are areas that can improve with this.
Next question is, can you talk about noteworthy things that you put in place in the last 5 years that will help your program going into the future?
Yeah, so that's a very good question. Probably something I would need to give more thought about because it depends on, you know, which program we're talking about. I think with regards to my own personal lab, one of the biggest strengths for me would be to have funding secured so that we can really explore some of the avant-garde, some of the cutting edge technologies. And being peer review funded brings so much validity and lends a significant weight to what we do and recognition. And so that is a machinery that brings additional funding and additional support and really very grateful for the grateful patients who support the work that we do, as well as the peer review funding. The Princess Margaret's strength in the foundation support is outstanding. So that, I would say, is something that has created an environment that we can really do anything exploratory today in the field of brain tumor research, truly, without exaggeration. And that's because of the funding, peer review, and foundation support through philanthropy and donations. In the Krembil Brain Institute, I think one of the biggest areas of impact has been building a framework where people can work together collaboratively and work within environments and groups in a supportive, caring, and respectful manner to be able to recognize each other's strengths and to build on it, as opposed to be competitive and to move in different directions. In neurosurgery, I'm very new in the field, in the role, and my hope is to recreate what I just mentioned we did for Krembil Brain Institute, is to bring people together more so that we see the value and strength of each individual and of each other. And in turn, it elevates all of us and it increases our strength. And as a team, we have hugely more potential. If you think of all the neurosurgeons across the city, there's 32 of us who manage over 7,000 pathologies a year by surgery alone. And so I think that would be infrastructure and features that I would like to build to enhance the work that we do at the university level and build for the future. Has philanthropy impacted my research? I already answered that hugely. Really, without philanthropy, it is impossible to do some of the very cutting edge research that we do in the lab. Some of the technologies, some of the application of technologies, some of the exploration of novel ideas are so unique that no granting agency, and specific in an area such as brain tumor research, it would be difficult to secure peer review funding because it's considered very niche, considered high risk. And though granting agencies and peer review are a mainstay of funding the activity that we do, the very cutting edge and niche ideas really are made possible by philanthropy and donor support. It's really, I think, one of our distinguishing features between an institution like ours and some of similar caliber, the strength of the foundation in particular at PMH.
Well, we have one more question. We're going to take that one offline just because we're a bit out of time and we want to be respectful of everyone's time. So thank you so much to everyone who submitted their questions to Gelareh. It's wonderful to still have so much participation. I think, as Gelareh said earlier, these new technology platforms, we never would have thought we'd have so much connection with people through Zoom. So this has been wonderful. Thank you so much, Dr. Gelareh Zadeh, for joining us today and for sharing your story and providing some really exciting insights into the future of neurosurgery.
Thank you, Meaghan. And I would say, I thought about it. The person I'd have dinner with would be my grandfather. I would really love for that to happen, but unfortunately he passed away and I hadn't seen him for so long. He was in Iran. So that had always been my answer. I think I have to go back to it. It would be my grandfather. Oh,
that's a beautiful answer. Thank you so much for sharing that with us. Okay, everyone, the link for today's session will be sent by email to anyone who registered, and you will have an opportunity to also provide valuable feedback through a short survey, which will be sent to you after the session. I'd like to invite everyone to join us at our next session on March 10th, where we will continue the conversation when we look at leadership in STEM, paving the way for the next generation of talent. As our next session, we will bring an amazing panel of women for International Women's Day. It is sure to be a fantastic discussion. You can register for that session at the pmcf.ca/webinar or via the link in the YouTube description below. Thank you so much for your continued support of the Princess Margaret. We hope you all remain safe and well, and we'll see you next month.